Hello and welcome back to the Learn Medicine Show. I'm Dr. Coleman, and in this video we are going to start our series on ECG interpretation. In this episode we will review 50 different ECG presentations, and along the way we will use animations to demonstrate what is happening with the electrical activity and why the ECG trace changes in normal and abnormal conditions. In the previous episode, we learnt how atrial depolarization is presented on an ECG as a P wave. Ventricular depolarization produces a QRS complex, and ventricular repolarization generates a T wave. Before we move on to interpretation, I want to add some intervals and segments to our trace. These are the PR interval, the ST segment, and the QT interval. I will explain what these are as we move on through the show, but for now we will use these waves, intervals and segments to structure our approach to interpreting normal and abnormal presentations. We'll start with P waves. P waves represent atrial depolarization, and they are best viewed in lead 2, where they will have a monophasic, smooth, dome-like shape. Let's take a closer look at this shape now with this diagram. The first portion of the P wave is formed by right atrial depolarization, and the second half is formed by left atrial depolarization. The normal P wave should have a duration of less than 120 milliseconds, which is the equivalent of 3 small squares. You can measure the P wave's duration by drawing a line at the start and end of the P wave and counting the small squares between the lines. In this case, you can see that the P wave's duration is 3 small squares. The amplitude of the P wave should be less than 2.5 small squares in lead 2 and less than 1.5 small squares in V1 to 6. To assess the amplitude, draw a line at the apex of the P wave and then count the small squares from the isoelectric line upwards. Here we are just shy of 2 small squares. Let us now review 2 abnormal presentations. These include tall P waves and notched P waves. We will start by looking at tall P waves. Tall P waves are caused by enlargement of the right atrium. The enlargement creates a delay in depolarization of the right atrium, and the thickening of the atrial wall muscle also produces a vector with increased amplitude. These factors combined lead to tall P waves. To better illustrate this, let's return to our atrial depolarization diagram. Note that increasing the duration and amplitude of the right atrial depolarization causes a change in the shape of the P wave. An additional contributing factor is that the peak depolarization of both the atria come closer together, illustrated by the peaks of the 2 triangles. This further amplifies the electrical vectors produced and leads to tall P waves. Tall P waves are often referred to as P pulmonale. To fit the ECG criteria, the P waves must be greater than 2.5 small squares in lead 2. In our example here, you can see that the P wave is equivalent to 3 small squares in height. If you decide to review the P waves in V1 to 6, they must be taller than 1.5 small squares. The duration of the P wave should be 120 milliseconds or less. In our example here, you can see that the P wave has a duration of 3 small squares, which is equivalent to 120 milliseconds. The cause of tall P waves is right atrial enlargement, and this is usually caused by conditions which increase the pressure of the right atrium, such as cor pulmonale, tricuspid stenosis, pulmonary hypertension, and congenital heart disease such as tetralogy of Fallot. Let's now focus on notched P waves. Notched P waves are caused by enlargement of the left atrium. In this scenario, right atrial depolarization occurs as normal and produces a first notch on the P wave. The delayed depolarization of the left atrium produces a second notch and also increases the duration of the P wave. Let's go back to our P wave diagram. Note that because the left atrium takes longer to depolarize, its peak amplitude is delayed, and this creates the second peak in the P wave. Notched P waves are sometimes referred to as P mitrale, and to diagnose this, the P wave should be assessed in lead 2. The P wave should have 2 peaks, and there should be at least one small square in distance between the 2 peaks. If we draw lines through the peaks on our ECG trace, you can see that there is at least one small square in size between them. The duration of the P wave is usually prolonged and is greater than 120 milliseconds. In our ECG trace, you can see that the P wave is nearly 4.5 squares in duration, which is equivalent to 160 milliseconds. Notched P waves are caused by left atrial enlargement, and this is usually caused by conditions that increase the pressure in the left atrium. These conditions include mitral stenosis, mitral regurgitation, hypertension, and left ventricular hypertrophy. Let's move on to the PR interval. The PR interval represents the time it takes for impulses to move from the sinoatrial node into the AV node and out to the ventricles. The PR interval begins at the start of the P wave and ends at the beginning of the Q wave. A normal PR interval should be around 120 to 200 milliseconds in duration, which is equivalent to 3 to 5 small squares. There are 2 groups of conditions that we will look at now when assessing the PR interval. The first is the atrioventricular blocks, and the second are the pre-excitation syndromes. Let's first take a look at the atrioventricular blocks. There are 4 different types of atrioventricular block, and they are all caused by an issue with conduction through the atrioventricular node or the bundle of His. We'll look at each one of the blocks now, starting with first degree heart block. In first degree heart block, there is a fixed prolongation of the PR interval due to slowed conduction through the AV node. Let's take a closer look at the ECG trace. The ECG criteria for first degree heart block is a fixed PR interval of greater than 200 milliseconds. Let's analyse this trace. We'll draw our lines at the start and end of each PR interval and then count the number of small squares. 200 milliseconds is equal to 5 small squares, and in each case here you can see that we have at least 9 small squares, which confirms our diagnosis. First degree heart block is caused by slow conduction through the AV node, and this typically occurs due to athletic training, AV node blocking drugs such as beta blockers, calcium channel blockers or digoxin. It can also be caused by age-related fibrosis of the AV node and ischemic heart disease. This condition is generally benign and requires no intervention. Second degree heart block is divided into Mobitz type 1 and Mobitz type 2. Let's look at type 1 first. In this condition, the AV node cells become fatigued and are unable to repolarize quickly. As a result, the PR interval becomes progressively prolonged until the AV nodal cells are no longer able to conduct an impulse. This occurs because the AV node cells enters their absolute refractory period when the impulse is conducted from the atria. Let's take a closer look at the trace and do some analysis. The diagnostic criteria for Mobitz type 1 is a progressive prolongation of the PR interval until a QRS complex is dropped. If we measure the two PR intervals here, we can see that the first is 7 small squares in length and the second is 9 small squares. After this, a P wave presents, but there is no QRS complex, meaning the electrical impulse has not been conducted to the ventricles. Mobitz 1 is caused by conduction fatigue in the AV node cells, and this is most commonly due to age-related fibrosis of the AV node. But other causes include ischemia, AV nodal blocking drugs, and increased vagal tone. Again, this condition is generally benign and does not require any significant intervention. Now let's focus on Mobitz type 2. Mobitz 2 is caused by abrupt loss of conduction through the bundle of His. In this condition, you should expect the PR interval to be normal size, because the problem is occurring after the AV node. Impulses are conducted as normal until there is failure of conduction through the bundle of His. Let's take a closer look. The diagnostic criteria here is an intermittent non-conductive P wave without progressive prolongation of the PR interval. In our trace, all PR intervals are normal at around 3 small squares in size. Note that a P wave occurs, but this is not conducted to the ventricles, so no QRS complex or T wave will follow it. Mobitz 2 is caused by a defect in conduction through the His-Purkinje system. The causes of this include myocardial infarction, age-related fibrosis of the conduction system, and medications that slow AV node conduction. Mobitz 2 does carry some risk depending on the frequency of drop beats. If they are very frequent, the patient may experience syncopal episodes. Temporary pacing is usually required for patients with a 2-to-1 or 3-to-1 block. The image here represents a 3-to-1 block where 3 impulses are conducted to the ventricles to produce a QRS complex and 1 is not. Next up we have third-degree heart block. In this condition, there is complete disconnect between the atria and the ventricles, meaning the P waves are generated, but they are not conducted through the AV node. QRS complexes and T waves do occur, but these are generated by a second pacemaker that is below the level of the AV node. Let's analyse the trace. In third-degree heart block, you need to be able to demonstrate complete dissociation from the P waves and QRS complexes. Note that the P waves are occurring at regular intervals, but they are not followed by QRS complexes. The QRS complexes appear to be occurring independently of atrial depolarization. Third-degree heart block is caused by complete AV node fatigue or defect in the His-Purkinje system. It is caused by inferior myocardial infarction, fibrosis of the conduction pathways, infiltrative diseases, medications that block AV node conduction, and congenital heart disease. Third-degree heart block often requires implantation of a pacemaker device, particularly if the heart rate is generally below 40 beats per minute, as this can lead to syncope. Now let's focus on pre-excitation syndromes. These present with a shortened PR interval and are due to accessory pathways that conduct electrical impulses outside the AV node and His-Purkinje system. Wolff Parkinson White is the example we will focus on here. Here is the most common accessory pathway for Wolff Parkinson White. Note that as impulses are conducted, they pass through the accessory pathway, which excites ventricular muscle. This creates an electrical vector which produces a delta wave in the PR segment. Wolff Parkinson White is a common presentation, so here is the ECG criteria. It presents with a shortened PR interval of less than 120 milliseconds. In our example, on the right, you can see that the PR interval is shortened to 2.5 small squares, which is equivalent to 100 milliseconds. A delta wave should be present, and the QRS complex is artificially prolonged due to the presence of the delta wave. The QRS complex should be greater than 110 milliseconds. In our example, the QRS complex is around 4 small squares in duration, which is 160 milliseconds. Wolff-Parkinson-White is caused by an accessory pathway for which there may be a genetic predisposition. It occurs with a prevalence of 3 cases per 1,000 people. Wolff-Parkinson-White is a significant presentation because the accessory pathway allows for an arrhythmia known as an atrioventricular re-entry tachycardia. We'll come back to this in the next episode of the show, which will be about arrhythmias. Now it is time to review the QRS complex. The QRS complex starts at the beginning of the Q wave and completes at the end of the S wave. The QRS complex represents complete depolarization of the ventricles, and its normal duration should be around 100 milliseconds or less. The QRS complex has various morphological appearances. In general, proceeding from V1 to V6, the R waves become taller while the S waves become smaller. This is known as good R wave progression. It's worth noting also, Q waves are not usually seen in leads V1 to 3. I have presented these outputs here because our next 3 diagnoses can be made by analysing the QRS complexes in leads V1 and V6. These are left ventricular hypertrophy, right bundle branch block, and left bundle branch block. The first diagnosis to review is left ventricular hypertrophy. Left ventricular hypertrophy is an abnormal thickening of the left ventricular muscle. The increased muscle fibre thickness generates a larger electrical vector. This means that as the left ventricle depolarizes, the S wave in V1 becomes very deep as the vector moves away from the electrode. Similarly, the R wave in V6 is also significantly enlarged as the current moves towards this ECG electrode. Note that ST depression and T wave inversion are present in V6. This is sometimes referred to as left ventricular strain and occurs due to the delayed propagation of the impulse through the thickened myocardium. This delay can cause some areas of the ventricular myocardium to repolarize early or later than others, and this asymmetric pattern of repolarization causes the ST segment depression and the T wave inversion. There are many ECG criteria for left ventricular hypertrophy, but the Sokolow-Lyon formula is perhaps the most popular. In this criteria, add the amplitude of the S wave in lead V1 to the R wave in either V5 or V6. The amplitude should be greater than 3.5 millivolts, which is equivalent to 7 large squares. In this image we have selected V1 and V6, so let's count the number of squares by drawing a line through the baseline of the ECG and the tip of the S wave in V1 and the tip of the R wave in V6. Note that an outcome of greater than 7 large squares is indicative of left ventricular hypertrophy. If we add each of these large boxes, the total number is 8.5 large squares, so this ECG is highly suggestive of left ventricular hypertrophy. Left ventricular hypertrophy is abnormal thickening of the ventricular muscle, and causes for this include hypertension, aortic stenosis, aortic regurgitation, cardiomyopathy, and coarctation of the aorta. Now let's shift our attention to right bundle branch block. Right bundle branch block is caused by a conduction defect in the right bundle branch. As a result, electrical impulses travel down the left bundle branch in order to get to the ventricles. The ventricular septum depolarizes normally, producing an R wave in V1. This is followed by depolarization of the left ventricle, which produces an S wave in V1 as the vector moves away from the electrode, and an R wave in V6 as the vector moves towards it. The electrical activity then moves to the right ventricle, slowly conducting through the ventricular muscle. This produces an S wave in V6 and an R wave in V1 as the current moves towards the electrode. The ECG criteria are as follows. There should be a prolonged QRS complex with a duration greater than 120 milliseconds or 3 small squares. In our example, the QRS complex is 5 small squares or 200 milliseconds in duration. An RSR wave should be present in V1 and an RS wave present in V6. The S wave in V6 should have a duration of 40 milliseconds, which is equivalent to 1 small square. In our case, the value is 2 small squares, which is 80 milliseconds. Right bundle branch block is caused by a conduction defect in the right bundle branch. This can be a normal variant or can be due to age-related fibrosis of the bundle branch, ischemic heart disease, cardiomyopathy, or pulmonary embolus. Now let's review left bundle branch block. A left bundle branch block is caused by a conduction defect in the left bundle branch. As a result, electrical impulses travel along the right bundle branch to gain access to the ventricles. This changes the polarity of ventricular septal depolarization and prevents Q waves occurring in V6. Right ventricular depolarization produces a vector which leads to an R wave in V1. This is followed by electrical activity moving into the left ventricle. As the first half of the ventricle depolarizes, a deep S wave is formed in V1 and an R wave is generated in V6. As the remaining portion of the left ventricle depolarizes, there is a notch that forms on the R wave. Due to slow conduction through the left ventricle, asynchronous repolarization of the ventricles occurs, resulting in ST elevation in V1 and ST depression in V6. To confirm left bundle branch block, there should be a prolonged QRS complex in leads V1 and V6. And this should be greater than 120 milliseconds or 3 small squares. In V1, there should be a deep S wave and ST segment elevation. In lead V6, there will be a completely positive R wave with no Q wave present or noticeable S wave. The R wave may be notched, and there should be depression of the ST segment. Left bundle branch block is caused by a conduction defect in the left bundle branch. Causes include age-related fibrosis, ischemic heart disease, hypertension, cardiomyopathy, cardiac surgery, and infiltrative diseases. Now let us focus on the ST segment. This represents the period of time between ventricular depolarization and repolarization. It starts at the end of the S wave and completes at the start of the T wave. The segment should be isoelectric, meaning that it is completely flat and should not have a positive or negative deflection. A key area of the ST segment is the J point. This represents the junction between the QRS wave and the start of the ST segment. The junction usually produces a clear angle, and you can use this point to determine whether it is above or below the ECG's baseline. There are 2 presentations to review here. These are ST depression and ST elevation. Let's start with ST depression. The most important cause of ST depression is subendocardial ischemia, so we'll focus on this as the cause of our ST depression. Subendocardial ischemia means that the blood supply to the internal surface of the ventricular muscle is reduced, and as a result, the cells will be deprived of oxygen and other essential nutrients. This will have an impact on how the cells in this area depolarize. As the area depolarizes, you can see on the trace that the J point is below the resting ECG baseline. Let us take a closer look to understand why. Here is a close-up of the left ventricular muscle. The healthy area is beige and the ischemic subendocardium is brown. The healthy myocytes will produce normal action potentials as they depolarize, but the ischemic cells will produce less positive action potentials. This is due to the lack of oxygen and nutrients, preventing the use of ion channels that require energy to open and close. The ischemic tissue is more negative during depolarization compared to the surrounding healthy tissue, and this establishes a voltage gradient between the tissues which generates an electrical vector moving from the healthy tissue towards the injured tissue. This is known as an injury current, and as the current moves away from our ECG electrode, a negative deflection is seen on the ECG trace, and subsequent ST segment depression occurs. ST segment depression can be horizontal or downsloping. The J point must be below the ECG baseline by at least half a small square. If we look at our trace, I've drawn a dashed line to represent the baseline, and here is the J point, which is at least 2 small squares below, confirming ST depression in this lead. For ST depression to be significant, it must be present in at least 2 contiguous leads, meaning that ST depression is found in 2 leads from either the inferior, septal, anterior, or lateral leads. ST depression is due to ischemic and non-ischemic causes. Non-ischemic causes include a normal variant, hyperventilation, left ventricular hypertrophy, left and right bundle branch block, and it can also be caused by digoxin and hyperkalemia. Next up is ST elevation. The most important cause for ST elevation is myocardial infarction. This involves full thickness ischemia of the myocardium caused by obstruction of the arteries which supply the ventricular muscle. In this case, the J point is elevated above the baseline as the myocardium depolarizes. The explanation for this again lies in injury currents. The cells within the ischemic tissue will again be deprived of oxygen and nutrients, which creates changes in the action potentials, making them less positive. This establishes a voltage gradient between normal and ischemic areas and produces an injury vector current which moves towards the outer surfaces of the ventricular muscle. This is perceived as a current moving towards the electrodes and subsequently produces a positive deflection on our ECG trace. The ECG criteria for ST elevation is as follows. ST segment elevation at the J point must be 1 small square above the baseline in 2 anatomically contiguous leads to be significant. So let's draw a line at the baseline and count the number of small squares up to the J point. In this case, the elevation is almost 4 small squares. It's important to note that this 1 small square of elevation applies to all leads apart from V2 and V3 where higher values are required. In leads V2 and V3, for males over the age of 40, the J point should be 2 small squares above the baseline. In males less than 40, it should be 2.5 small squares above the baseline. and in women it should be 1.5 small squares above the baseline. The most common presentation of ST elevation is myocardial ischemia, which is why we are focused on this cause here. But there are also non-ischemic causes, and these include pericarditis, benign early repolarization, and left ventricular hypertrophy. Now let's focus our attention on the T waves. T waves represent ventricular repolarization. They are typically upright in all leads apart from AVR and V1, where they are inverted. The amplitude of T waves should be less than 5 small squares in the limb leads and less than 10 small squares in V1 to 6. To measure the amplitude, draw a line at the apex of the T wave and count the number of small squares from the baseline upwards. In our example here, you can see that the T wave has an amplitude of 2.5 small squares. The T wave shape is normally a rounded dome but is asymmetrical. There are 2 presentations I want us to cover here. The first is the peaked T wave and the second is T wave inversion. Let's take a look at the peaked T waves. We will use hyperkalemia here as our example of peaked T waves. Hyperkalemia is a very important diagnosis because it can lead to dangerous arrhythmias. Hyperkalemia is caused by an elevated serum potassium greater than 5.5 millimoles per litre. As the serum potassium level rises above 5.5, the first ECG changes to occur are peaked T waves. As the potassium level rises further, additional changes are seen, and we'll cover these here so that you are able to identify them in future. The raised potassium has an impact on the heart at a cellular level. It causes abnormalities in the ventricular myocyte action potential. For example, the cell's resting membrane potential becomes less negative. The overshoot becomes more gradual and prolonged, and the overall duration of the action potential is shortened significantly. These changes have 2 consequences. The first is that the prolonged upstroke causes much slower progression of impulses through the conduction system. The second is that the shortened action potential means that the repolarization time is reduced. This rapid repolarization time results in an increased electrical signal and produces our peaked T wave. We'll take a closer look now at the ECG features of hyperkalemia. The electrical activity will flow through the normal pathways, but the slowed conduction produces flattened P waves, prolonged QRS complex, and the rapid repolarization time produces very peaked T waves. The ECG criteria for peak T waves are as follows. Peak T waves should be present in more than one lead to be significant. In the limb leads, they should be greater than 5 mm or 5 small squares in height. In V1 to 6, they should be greater than 10 mm, which is equivalent to 10 small squares in height. In our example here, the T wave is 15 small squares high. Peak T waves occur due to an increased repolarization signal. And this is caused by hyperkalemia, myocardial infarction. It can be a normal variant or can be caused by left ventricular hypertrophy or left bundle branch block. Next up is T-wave inversion. The most important cause of T-wave inversion is myocardial infarction. Consider T-wave inversion as an alternative presentation for subendocardial ischemia. In this presentation, as the electrical activity flows through the heart, ventricular depolarization occurs. But as we get to repolarization, the ischemic cells cause a change in the repolarization vectors and produces our inverted T wave. Normally, repolarization of the ventricles starts in the epicardium and moves towards the endocardium. This occurs because the action potentials of the epicardium are much shorter in duration and therefore repolarize earlier. In the myocardial ischemic cells, the action potential duration at the endocardial level is reduced, and this flips the direction of repolarization, with the endocardial cells repolarizing first, and this subsequently changes the vector perceived by overlying electrodes. The ECG criteria for ischemic inverted T waves is as follows. The inverted T waves should be greater than 1 small square in depth and must be present in at least 2 anatomically contiguous leads to be significant. This excludes AVR and V1, where T waves are naturally inverted. In our example here, you can see that the T wave is negative and has a depth of 2 small squares. T-wave inversion is caused by the reversal of repolarization currents, and this can be due to myocardial infarction, hypertrophic cardiomyopathy. It can be a normal variant, particularly in children, and can also occur in raised intracranial pressure and pulmonary embolism. The final area to explore in this show is the QT interval. The QT interval represents the duration of time taken for ventricular depolarization and then repolarization. It is measured from the start of the S wave to the end of the T wave. The QT interval may vary as the heart rate changes, and as a result, the corrected QT interval, known as the QTC, is used to account for this. Most ECGs will calculate the QTC for you, but here is a formula if you wish to calculate it yourself. In lead 2, identify the longest QT interval. In our example, the QT interval is 10.5 small squares in duration, which is equivalent to 420 milliseconds or 0.42 seconds. In the QTC equation, the two R's represent the RR interval. This represents the duration between the R waves. In our example, this is 1000 milliseconds or 1 second. If we add these numbers into the equation, the corrected QTC in our example is 0.42 seconds, which is equivalent to 420 milliseconds. The normal corrected QT interval should be less than 440 milliseconds for males and less than 460 milliseconds for females. Prolongation of the corrected QT interval is the most important diagnosis to consider here. The corrected QT interval is prolonged if it is greater than 440 milliseconds in males and greater than 460 milliseconds in females. A corrected QTC of 500 milliseconds or more is associated with a dangerous ventricular arrhythmia known as torsade de Poix. We'll review this arrhythmia in more detail in the next show. Prolongation of the corrected QT interval means that ventricular depolarization and repolarization are prolonged, and the causes for this include electrolyte abnormalities, medications that prolong the QT interval, such as antiarrhythmics, antipsychotics, antibiotics and antidepressants, myocardial infarction, hypothermia, and there are genetic conditions which naturally cause a prolonged QT interval. And this brings us to the end of today's episode of the Learned Medicine Show. Here is a summary of all of the ECG presentations we have reviewed and the ECG criteria. You can screenshot this with your phone and keep it there for revision. Don't forget to like, subscribe and hit the bell so that you are notified when more content is released. In the next episode, we are going to be looking at cardiac arrhythmias. We will add to our interpretation of the ECG by looking at rate and rhythm. For now, thanks for stopping by, and I'll see you in the next show.